Fun. And welcome everybody to this week's Maternity and Midwifery Hour. My name's Sue Macdonald and I'm the curator of the Maternity and Midwifery Festivals and the Maternity and Midwifery Hour, and it's my pleasure to be chairing this session this week, and we're in Series 9. I can't believe it, and this is session number 3, and I'm joined by Mairi, and I knew I'd pronounce it incorrectly, I'm so sorry, Mairi Harkness, Research Fellow at the University of Stirling, and Dr. Cassandra Yuill from City, University of London. And they're both with us. And because we always mean to them, we always ask our guests to share a moment of the week. So please, can you share your moment of the week? And maybe we'll start with Mairi.
Well, my moment of the week probably is today, which is Burns Night. So always a bit of a special one in our family. And I got a lovely text this morning from a friend with a little quote from Burns that just made me laugh. So that was quite a nice moment of the week.
Wonderful. Thank you for reminding us it's Burns Night. That's wonderful. So all over Scotland, there'll be haggises being piped all over the place and dancing and much merriment. So it's lovely. Thank you, Mairi. And Cassandra, please share your moment of the week. It's a special one too.
My moment of the week is more of an academic professional moment. I had a paper come back with very, very minor revisions, which doesn't always happen. So that was a big highlight of my week for my co-authors and I. So
wonderful. Well done. Fantastic. And I think the academics out there watching will have a lot of fellow feeling with you, because it's a big thing. Putting in a paper and then waiting for it to come back with comments and revisions. It's a big thing, isn't it? So congratulations, Cassandra. And Mairi, thank you so much. So I'll do the usual little start off, just for those of you who are new to Maternity and Midwifery week, or our midweek, I'm taking a week now. We started this right at the beginning of the pandemic in 2020, which is why we're on Series 9 now. Really as a way of getting midwives and student midwives and other people in the maternity services connected, and also having access to some information, continuing professional development, because we couldn't have study days, we couldn't have festivals or conferences or real face-to-face events. So we needed something to connect everyone and also keep our revalidation busy. So this has continued because we've kind of changed the character of some of the things we're putting in, but the idea is still to make sure that we can connect with midwives and student midwives and anyone else who likes to join us, and not just in the UK but all over the world. So welcome to everyone who's not from the UK, and I know we have a loyal following in New Zealand and Australia and Nigeria and Pakistan and India. So welcome to you, and actually Saudi I know we have. So hello to you this evening. And just to remind you that everything that we do on the Maternity and Midwifery Forum is always recorded, and we record it so that we can keep things and share things. And we have a huge archive, and it's well over 1,000 sessions of recordings, which is looked after by the great Matflix, the midwifery experts. And you can access these for free. You just have to search down on the Matflix page. Or if you want a really concentrated topic, you can subscribe for a small fee every month, and you'll get these lovely box sets, which is managed by the lovely Dr. Jenny Hall, and those have lots of reflective incidents and things to look at and activities, and they can be really, really useful. This is fantastic if you're doing a project, or you're doing a revalidation, or you're just wanting to refresh yourself on some topic. There's lots and lots of resources for you. So please do access and share. And if you enjoy this evening, and I know you will, tell your colleagues about it. It's all free to come in and watch and share. And there'll be a podcast at 6 o'clock in the morning of this very evening. 6 o'clock in the morning, for those of you who want to do maybe some exercise or running, to be listening to all these words of wisdom we're going to hear this evening. So share and use. No, I want to say a big thank you to our lovely midwives, our lovely student midwives, maternity care support workers, everyone who's working so hard in the maternity services. Also, though, of course, in the NHS. And I know at the moment there's so many things going on. It's really difficult and really quite stressed for everybody. And I know there's been industrial action going on. And I know midwives feel very strongly about that and supporting our nurse colleagues and our ambulance colleagues in this. And I'm hoping maybe things will be resolved. I wish it would be resolved, because we need to look after our people and pay them well. I'm being a little bit political here, but also support them and look after them. And I know that people are working really hard to keep everything going and keep the services going. So a big thank you to everyone who's doing that. And also those of you who are covering for sick leave and absences and any shortages in the service. Just keep going and look after yourselves, because you need to look after yourself to be able to look after others. I know I always say this, but I really mean it, and you need to remember it. Even if you just look in the mirror in the morning and say, I need to look after myself, that's your homework for tonight. Now, I've just got little bits of news before we get on to the main meat of the evening. And the first bit of news is this Friday is International Holocaust Remembrance Day. And this is a really important day for us to remember how difficult life can be, and how many things in the past have been done that are wicked and bad, and how many things are still being done that are wicked and bad, done by ordinary people. And interestingly, the theme this year is ordinary people, and it's the highlighting that some ordinary people can be responsible for things like genocide by turning a blind eye, by joining a regime, or by doing things themselves, or just allowing them to be done. And of course, on the other side of that, there are ordinary people who are having dreadful things done to them just because they're in the wrong group or in the wrong place. And I think it's worthy of remembering. And I know that many people on Friday will spend some time thinking about the things of the past and the things of the future. So I thought I needed to note that. That makes me remember that on the resources sheet, there is a link to the International Holocaust Remembrance Day. And it's quite interesting to have a look at that. It's got little case studies, and it really brings to life the experiences of people that is important for us to remember. And okay, and there's also, I think, another thing that hit me this week in the news was these refugee children that have just vanished or been taken away from a hotel in Brighton. And that sort of thing needs to concern us, and we need to be observant ourselves of things that are going on in the world. A little bit of political again, I'm afraid. Apparently some of the children have been found, but there's still some missing. And I think we need to put some pressure to make sure the children are as safe and cared for as we want our own children to be safe and cared for. Now, on a bit of a cheerful note, it's a very happy Burns night to all our Scottish friends and colleagues. And I hope your haggis is spicy and your whiskey is smooth for this. And I know there'll be a lot of celebrations this evening. I hope that's good for if you're involved in one of those and you're eating your haggis. But I'm almost exactly on time, almost time. I'm keen to get into this topic or into this area, because I know that, and I said this to Cassandra and Mairi, that I love to get research hot off the press, but also being talked about and presented by the people who've been involved with it, because it really comes to life. Sometimes, and I know some of you would be thinking, especially if you're doing a lot of studenty things, oh, more research, oh, it's a bit heavy. But actually, when you listen to it like this, it really does come alive. And listen to the methodology if that's something you find a bit difficult, because it really does. This is real people, real research, and real findings that can be put into practice. Really exciting. So tonight we're looking at cervical ripening, the process of softening and opening the cervix before the start of labour. And traditionally, this is a very much an in-hospital thing, and it's allowed the monitoring of maternal fetal well-being and early recognition of any complications. But increasingly, a number of units are offering outpatient cervical ripening. And in this hour, Mairi and Cassandra are going to discuss home cervical ripening versus in-hospital cervical ripening, determine whether home cervical ripening is acceptable from the perspective of women and the NHS, i.e. the people who are working in the NHS. And we're going to start with Mairi. And Mairi is a registered midwife, an honorary senior research fellow at the University of Stirling, and she's got broad experience now. She says broad, I suspect it's very wide and broad as well, across midwifery education and research within UK higher education institutions and the NHS as a midwife. And she's going to be talking first. So welcome, Mairi. The screen is now yours.
Thank you. Let me just start this presentation.
Wonderful.
There we go. Okay, thanks. Thank you very much. So I'm going to talk today about work that was undertaken during the CHOICE study. So that was, the CHOICE study is cervical ripening at home or in hospital, a prospective cohort study and process evaluation. I'll explain a bit about the CHOICE study, present some findings from a postnatal survey that we did, and then I'll hand over to my colleague Cassandra Yuill, who will present another piece of work from CHOICE. So first of all, a little bit of background. Induction of labour now accounts for between 30 and 50% of births in the United Kingdom. So that's between 240 and 400,000 per year. We know that it affects experience of childbirth, but there's actually very little evidence about experience of induction of labour. Cervical ripening is now recommended as first stage of an induction of labour for most people, and it involves application of either a pharmaceutical agent, so that would be a pessary or gel, which is usually prostaglandin, or a mechanical method, which would be a balloon catheter or osmotic dilator, such as Dilapan, which are inserted into the cervical os to soften, shorten, and or open the cervix in preparation for labour. So cervical ripening is now offered at home for some people. They attend hospital for assessment and insertion of the cervical ripening agent, and then they return home, coming back to hospital when they're in labour or after a set period of time, and that's sometimes 12 hours and sometimes 24 hours. So the work we're presenting today was undertaken as part of the CHOICE study, and CHOICE was a multidisciplinary UK-wide NIHR-funded study looking at the efficacy, safety and acceptability of cervical ripening at home and in hospital. It's led by the University of Edinburgh, University of Stirling and City University of London. And we've got a fantastic team of people who've been working on CHOICE, which includes obstetricians, midwives, social scientists, neonatologists, statisticians, health economists. I've probably missed someone out, but a big team with a huge range of expertise. The main CHOICE study analysed data from thousands of inductions of labour, and that will report on the safety and the efficacy of the setting and the methods used for cervical ripening. But today we're presenting Q-CHOICE findings, which are around experience. So Q-CHOICE was the qualitative part of the CHOICE study, a qualitative process evaluation, and that has focused on women, service users, birth partners and staff experiences of induction of labour. And I'll talk about a postnatal survey that we did, and then Cassandra is going to talk about the case studies, which were interviews and focus groups. So the postnatal questionnaire-based survey that we did, this was an online survey, and we invited women and birthing people who were having an induction of labour at 37 or more weeks gestation to complete the survey. They were recruited via their Badgernet Maternity Notes app, so that's an electronic maternity note system, through social media and on postnatal wards with research midwives. At the end of the survey, they were invited to leave a contact, and then that way we were able to follow some of those who completed the survey up for interviews. So the survey was open between February 2021 and April 2022. We included lots of questions around the views and experience of key elements of the induction of labour process. Satisfaction, sense of control and mental well-being were based on tested tools. So those included WEMWEBS, which is the Warwick mental well-being tool, the Labour Agency Scale and Henry, and the references for those are actually on the final slide. So you'll be able to, if you're interested in those, the references are there for you. The survey included fixed responses and free text, which allowed us to produce descriptive statistics and qualitative thematic analysis. So we ended up with 309 eligible responses from women who'd had an induction of labour at 25 NHS trusts and boards across Scotland, England and Wales. Only 36 of those had actually returned home during their cervical ripening, so that was just 14%. So with so few respondents returning home, obviously this impacted our data analysis, so we were no longer able to do statistical comparison between the two groups. But we do have descriptive findings from the women who went home. And in addition, those who left contact details were followed up for interview, and Cassandra is able to talk about those later on with the case studies. So the survey was long and it's not possible to give all the findings, but I have summarised some of the key ones for you for tonight. So first of all, we asked a series of questions about decision-making around induction of labour. We found that 57% of the women who responded said that they either felt they had no choice or no alternative option about having an induction of labour. 66% felt that the options were explained in a way that they could understand, which of course means that a third of them felt that that wasn't the case. And exactly half felt that they fully understood what to expect during induction of labour, which again means that of course half didn't understand what to expect during their induction of labour. Thinking about the first question there, where we asked where women felt that they had no choice or no alternative option about having an induction of labour. This lack of choice was something that was often linked to induction of labour being presented as the only safe option for them. So this quote from a woman says, "It was never something I had a choice in, and I was told that if I didn't get induced, there was a high chance of my baby being stillborn because I was almost 42 weeks. So this scared me." And that was a very common thing around feeling that you didn't really have a choice about induction of labour, that it was the only safe option for you. So choosing an induction of labour had an immediate impact on birth plans for around half of our women. 48% reported that it changed their birth plans. The most common was being no longer able to use water during labour or birth, or being unable to use a midwifery-led unit. And again, I've got a couple of quotes here. So one woman said, "I would have liked a water birth, but was told this was no longer an option." And another said, "I was devastated I couldn't go home from my birth of my first baby." So moving on to cervical ripening and starting with the method being used, you can see here we ask questions about the discomfort by the type of cervical ripening method. So level of discomfort and ability to cope with discomfort varied between the different methods of cervical ripening that were used. Those who had balloon catheter reported more discomfort than those who had pessary or osmotic dilators. Although interestingly, ability to cope with discomfort was similar across all the cervical ripening methods. So when it came to going home or staying in hospital, only 39 respondents were actually offered home cervical ripening, and 36 of those, so 14% of our respondents, returned home. Not all maternity units offered home cervical ripening, and for those that did, there were often quite strict criteria. So for example, in many units, you had to be being offered induction for post dates, be low risk, and then there would be additional criteria that varied. For example, you maybe had to live within a certain distance of the hospital, or have someone at home, or have your own transport, and those type of things. So there were quite a lot of restrictions on who could be offered home cervical ripening. And very interestingly, most of the women, not all of them, but most of the women who did go home were from one particular maternity unit. And at that maternity unit, cervical ripening was the default. So everyone there who had cervical ripening returned home unless there was a really compelling clinical reason for them not to. So you can see that actually, even at the point of being offered it, and the choice about this is being restricted. So with choice around place of cervical ripening being limited, some people who'd returned home felt that they didn't have a choice to stay in hospital, and then others who stayed would have liked the option to return home. Women varied in what they wanted. One woman said, excuse me, I've got a bit of a cold. One woman said, I was not offered the choice to stay in hospital after my balloon was inserted. This would have made all the difference with a toddler at home. But we actually had an almost identical quote from another woman saying that she would have preferred to have been at home because she had a toddler. So there appeared to be lack of choice about whether to return home or to stay in hospital. Circumstances obviously differ, and personal preference is important, but that didn't seem to be being taken into account by caregivers. Women didn't usually have a choice about method of cervical ripening, despite the variation in the ways that they work and the discomfort levels between the methods. And the method offered was often decided by setting. So, for example, pessary was only available for those who stayed in hospital, and balloon or dial-a-pan for those who went home. And some women reported that they'd chosen either to go home or to stay in hospital, not because of the setting, but in order to receive their preferred method of cervical ripening. So, moving on to experience of cervical ripening in hospital and prior to labour ward. So we asked women about the time that they spent in the antenatal area before transfer to labour ward. And the median stay before transfer to labour suite was 22 hours. However, many were in the antenatal area for several days, and the range was 0 to 260 hours, so that's 11 days. The women reported that poor staffing led to significant delays in transfer to labour ward, particularly when they needed an artificial rupture of membranes or when they were in labour. So there was this significant number of women who really spent days on the antenatal area. We had 100 who spent over 24 hours, 42 who spent over 48 hours, and it really wasn't uncommon to hear women talking about having spent 3, 4 or more days. And then, of course, we had this one poor woman who was there for 11 days, and she said staff were pushed to the brink, which is why I was in the hospital for 11 days before my waters were broken. So this became problematic because the antenatal area was often described as inappropriate by the women. They reported being upset because they were separated from their birth partner. There was lack of privacy, there was lack of support, there was inadequate pain relief. And the delays, there was certainly a sense among the women that they were further down the labour ward waiting list because they were already in the antenatal area, and they had a bed already, even although it wasn't a labour ward bed. So the lack of urgency during the induction of labour process often sat in opposition with the sense of risk that had been communicated as a reason for induction of labour. So unsurprisingly, the delays created a great deal of anxiety when women had been told that they were being induced because of an increased risk of stillbirth. So this woman said, when you've been told for 3 months that your baby could be in danger if you reach 39 weeks, and then you have to go beyond that because they don't have a bed for you, it's a very scary time. And that was a fairly common sentiment that we heard. So the delays that we heard about were this delay in initial admission to begin induction of labour, but also these compounding delays where women couldn't be transferred to labour suite when they needed their ARM or in established labour. The delays meant that some women laboured in the antenatal area, and it impacted their experience, and it had some safety implications as well. So this woman said, I was told I couldn't have an epidural until I moved to labour ward, but I couldn't move to labour ward as it was full. I was only moved when I was pushing. And another one said, I was labouring behind a curtain, no privacy, others all around me. It was really hard to focus and stay calm and relax with no privacy of my own, no pain relief and no food. So a pretty unpleasant experience overall. Something that was very important to the women that came out throughout the survey was the support of their birth partner and their birth partner's experience. Birth partners were described as a really important source of support for the women, but unfortunately they were often treated poorly. They couldn't be present as much of the time as they and the partner and the woman wanted, and sometimes they missed the birth. So this survey happened during the COVID pandemic. We know that some restrictions were in place in some places, but we do also know that many units have policies that restrict birth partner presence in normal times during cervical ripening, often limiting it only to during visiting hours. And a common story around partners missing the birth was that a woman her cervical ripening would start to work. She would go into labour, and if that happened during the night, the partner would have been sent away home. She would be on her own, and she wasn't allowed to call the partner to come back in until they had a bed on labour ward. But of course, sometimes that all happened very quickly in the end, and there was a rushed move to labour ward and the partner wasn't able to get back in time, which is absolutely devastating to miss the birth of your own child. And there's this quote from a woman who said, the birth partner, had nowhere suitable to wait as we live 3 hours away from the hospital, and this made him anxious as he wasn't there to support me. It also made me anxious as I knew he was waiting for news and worrying while he wasn't with me. And this was a woman who had initially booked at the midwifery-led unit, which was closer to where she lived. But because of an induction of labour, she had to travel to the obstetric unit, which was much further away. And that really wasn't taken into account by the staff, and nothing was done to support the birth partner within that. So unsurprisingly, unfortunately, the delays and the poor experience impacted safety and well-being. 41 of the women who left free text comments described their induction of labour as traumatic and or having caused significant long-term negative impact on their physical and or mental well-being. And this one woman said, it was all so horrendous, I'll never have another child. It gives me anxiety thinking about it all. Before this experience, I did want more than one child, which is just absolutely horrible to read, isn't it? But on a happier note, there were people who had a good experience within the survey. There were fewer of them, but they were there. And the most important factors in a positive experience was support from kind, caring staff and being made to feel safe, valued, respected. Things that we as midwives have control over. And there's this quote that said, my midwife was incredibly supportive throughout labour and birth. We felt safe and well cared for. So just in conclusion, induction of labour rates have increased, but planning facilities, resources for effective services don't appear to have. Genuine informed choice and information about what to expect appear to be lacking, and this results in poor experience of induction of labour and unsafe situations. Few women are having home cervical ripening. More research is needed about their experience, and certainly facilitation of individual choice about whether to go home or stay in hospital is important. And I've put the references at the end of the slide, so they'll be available later. And just to let you know that if you're interested in reading more about the postnatal survey, there's a preprint publication available as well. And I'll hand over to Cassandra now.
Okay. I better introduce Cassandra. No worries, but thank you, Mairi, because I know you've got a really bad cold and your voice held up beautifully. And I hope you'll be holding up for the questions that are coming. There are already some questions coming in. So well done to the audience for already. We have a fab audience and they always come up with good questions, and they're coming up with some now. So the next speaker is Dr. Cassandra Yuill. Hope I pronounced that correctly, Cassandra. And she's a medical anthropologist and research fellow in the Centre for Maternal and Child Health Research City, University in London. Her work focuses on maternal health and maternity services, particularly in the UK, and she's conducted research on parent-infant sleep, place of birth and induction of labour. She's currently undertaking projects on midwifery-led care and perinatal mental health. So welcome this evening. And now, Cassandra, the screen is yours.
Thank you so much. So just go ahead and share my screen. And thank you so much for having both of us. Oops, not on the right slide. Let me go back to the beginning. Okay. Thank you so much, Mairi, for starting us off. I'm going to now go through the research that we did on clinicians' perspectives and experiences of providing cervical ripening at home or in hospital. And I'm not going to give an overview of what we did because Mairi already did that, and I'm going to be giving quite a brief summary of the findings. But again, this is in our preprint, so if you are interested in more detail, it can be found there. So just a little bit about the background and aim for this part of the research. So the offer and practice of home cervical ripening is inconsistent both within and between institutions. And this is something that we found as part of a survey that we did during the COVID-19 pandemic. See reference there. And there's also a paucity of literature on clinicians' experiences of providing induction of labor in general, despite their central role in developing guidelines and delivering this care. There's also very little research on different approaches to cervical ripening in practice and on the safety and acceptability of home cervical ripening, which is why we were doing the choice study. So the aim of this was to explore induction of labor, specifically cervical ripening, and the option to return home during that process from the perspectives of midwives, obstetricians, and other maternity staff. So just a little bit about the method and analysis, which I know Mairi really gave a good introduction about. So this data comes from semi-structured interviews and focus groups that were conducted with clinicians working in the 5 Q-choice sites, case study sites in England and Scotland. And all interviews and focus groups were conducted by myself, Mairi, and our colleague Clarice Wallace between November 2020 and December 2021. So we were doing this research, as Mairi said, during some of the heights of the COVID pandemic. So first I'm going to go through the descriptive findings. So in all, we did 48 interviews, and you can see the numbers on the side there, and 4 focus groups. We had a total of 76 participants in all. And we had a lot of midwives, obstetricians, and some other NHS staff, as well as stakeholders. So we found that all 5, so part of this research, we did ask about policies, induction of labor policies at each of the 5 sites. So all 5 of the case study sites provided home cervical ripening. A lot of local policies changed due to COVID-19 restrictions, with one site suspending the service for majority of the study time. And the policies for induction varied between sites, which is consistent with our survey that we did on practice changes during COVID-19. I have a table here just sort of outlining some more details about all of the 5 case study sites. As we said, I know it might be hard to read. We have a much longer, much more detailed paper in the preprint if you are interested in looking at this a bit more. But there was a lot of variation in the methods used for cervical ripening, specifically home cervical ripening, which Mario has been mentioning earlier, the different, so some used dilapan, some used a balloon catheter. One of our sites even used prostaglandin for home. And there was a lot of variation between, who was being offered to go home, as well as the eligibility criteria for going home too as well. Okay, so now I'm going to move on to the thematic findings. So the thematic findings were generated through an in-depth analysis of the interviews and focus groups, and are grouped to reflect the induction of key points along the induction of labor process, specifically when you're providing induction of labor, specifically cervical ripening care. So the first one is implementing home cervical ripening. putting local policy into practice, giving information about induction, and providing cervical ripening. Okay, so most clinicians who took part were positive about cervical ripening. Most perceived it to be better for themselves in terms of managing maternity workload, and also for women and their families, especially those who were deemed low risk and healthy. However, the use of home cervical ripening, as I said, varied between sites, and many were not offering home cervical ripening widely in practice. Some of the motivations for introducing home cervical ripening were stated as reducing unnecessary time in the hospital for women, linked to the perception that women would prefer to be at home and that their experience would be improved by offering home cervical ripening. And significant groundwork, such as knowledge building, cross-boundary collaboration, and confidence were all cited as key for implementing it. And the next quote I have sort of shows, what happens when these sorts of things break down. So this midwife is talking about how women were being given the proper information about home cervical ripening, and so they weren't keen for it. And they're talking about how one element in this chain is not performed, then it impacts the way that this is implemented across the entire service. Okay, so putting local policy into practice. So participants, as I said before, were asked about their local induction of labor policy or guidelines during interviews and focus groups, which reveal these intricate care pathways involving many different actors and places. And I know it's going to be really hard to see, but the figure on the right details the sort of the flow of this care pathway. And it's based on an interview that I did with an obstetrician. And you can just see all of the different things that happen during this care pathway and the different places that this involves, as well as where some of the delays occur. So induction of labor policy dissemination was described as uneven and difficult to access. Induction of labor was typically offered and booked by midwives for those who deemed low risk, and by obstetricians for those who were deemed high risk. And midwives were expected to take on new roles with home cervical ripening, including inserting catheters or the osmotic dilators, as well as the logistics of managing women both in hospital and at home. So this midwife is talking about just some of that setup, some of that groundwork and getting this policy into practice, talking about providing training for midwives because they wanted this service to be midwifery-led, and the challenges that you face as a midwife when you're trying to set that up and to doing this induction of labor procedure, and the challenges for women going through that induction procedure, and talking about how keen they were to get this up and running and having the guidelines all set, again, doing all that groundwork, and then having the impact of the pandemic on staffing, and that really impacting their ability to do outpatient induction of labor or the home and cervical ripening. And as we said, we did see impact from COVID during this study, of course. Okay, so moving on to about giving information about induction. So participants often spoke of a mismatch in perspectives between themselves and those undergoing induction of labor. Managing expectations using realistic information about induction of labor was viewed as crucial for closing this gap. But time and resource constraints, such as tools and evidence, were identified as obstacles to effective information giving and risk communication. And I've just got some quotes to illustrate this here. The first comes from a midwife talking about the lack of time that community midwives have. They have a 20-minute appointment. They have to do the normal antenatal check, and then you have to discuss induction of labor with them. And this is obviously, as we saw that earlier figure, the flow, the sort of induction of labor is quite a complex thing to discuss, and that's really that limited amount of time. And then this next quote comes from an obstetrician talking about the lack of tools to have this discussion, having infographics, not having anything in different languages other than English to help people understand this complex process, as well as the lack of evidence that gives this sort of induction of labor process this uncertainty about it too as well, in terms of giving information. Okay, so finally, I'm going to talk about providing cervical ripening. And I know Mairi has also detailed quite a little bit about, the context of which people were undergoing cervical ripening, as well as now providing that care. So delays were an issue throughout the induction of labor process, frequently occurring between the cervical ripening procedure and admission to labor ward for ARM, as Mairi has talked about. Participants and clinicians in this part of the study attributed delays to inadequate staffing, while some suggested home cervical ripening would create its own set of logistical issues. Most believe that it would be a solution to the delays and dissatisfaction with the induction of labor process. There were conflicting views on the impact of home cervical ripening on workload. Some felt it made workload easier to manage, while others did not. And I've just got a couple of quotes here. They're quite long, so I won't go into them in detail, but this midwife talking about ringing women on a waiting list to come in for their cervical ripening at 1 o'clock in the morning, at 3 o'clock in the morning, to bring them in, and talking about this process, this system of going down this list of having, when they have capacity, ringing women in the middle of the night several times, documenting it, moving on to the next one. And if they don't pick up, moving on to the next one, and just doing that until you get every single one in. And again, this is, this extra administrative workload connected to this. And then finally, from this midwife, talking about the challenges, particularly, and the risks that could even be associated with the current staffing levels at the moment. Again, only being able to get a woman to a certain point in the induction of process, and if there's no midwife available to give them the one-to-one care in labor ward, to be able to break their waters and get on with it, because obviously once that's done, they have to look after them. And if they don't have the staff, that's when you end up with this delay. And so talking about, not being uncommon to see these delays for 24 hours, and the many women just sitting on the wards, just waiting for something to happen. And also, talking about being aware of the fact that with the staffing levels the way that they are, because the staffing shortages were even apparent, obviously, during COVID, and after sort of the levels of COVID started to reduce too as well, there were still issues with the staffing levels, would not really completely remove that risk by doing outpatient induction or the home cervical ripening. Okay, moving on to the discussion. So implementation of home cervical ripening varies across the NHS, given the uncertainties that surround it, including gaps in the evidence and unpredictable nature of maternity care work. A range of practices and views on induction of labor were recorded, and we've got more in the preprint in the paper if you want to look at that, particularly around the methods used, showing how the integration of home cervical ripening is not always straightforward, and how deviations from local guidelines might occur when put into practice. So home cervical ripening appears to be about improving women's experiences, but is also strongly linked to workload. It was largely seen as a solution to operational challenges of induction of labor care. However, this perspective is based on underdeveloped and at present inconclusive evidence about the safety and efficacy of home cervical ripening and the impact on workloads and resources. Participants were often looking for strategies to manage workload, and home cervical ripening was one proposed solution. Yet they highlight the ways in which this expectation might not be borne out in practice. Home cervical ripening did not necessarily lessen workload, but rather shifted it from one space or person to another, and in some cases increased it. So our findings also highlighted the service's limited preparation for increased induction of labor rates in terms of workload changes and additional staff time and stress. And throughout the induction of labor process, from giving information to providing cervical ripening, time was limited and delays were frequent. Clinicians reported efforts to keep the process moving, even if this meant calling women repeatedly in the middle of the night when staff and space became available. So this process production approach to care responds to the pressure on staff and services. And this post-production approach is sort of, something that we talk about, sort of that more industrialized model of approach to healthcare. So it responds to the pressure on staff and services, but disregards the well-being of women physically and psychologically, as Mairi has detailed in her discussion, in her talk. And so women need to fit the system, or they miss out, passed over for the next person on the list. This approach sits in opposition, in our view, to national maternity policy ideals of person-centered and compassionate care. However, it was a way for staff to cope with the unmanageable workload connected to increasing induction of labor rates. So this process production approach, coupled with expectations of home cervical ripening, are indicative of a trend, in our view, towards routinization of induction of labor in maternity care. Induction of labor, as we argue, is not without lateral effects and represents a significant workload in the UK maternity services, which are currently experiencing acute staffing shortages. And in light of this, we argue making induction of labor more routine, whether at home or in hospital, should be reconsidered, and its potential risks, including unintended effects and those beyond the usually recognized clinical scope, require further scrutiny. Home cervical ripening is not necessarily a solution. Thank you so much. This is the link to our survey, the preprint, and as well as to our survey that we undertook during the COVID-19 pandemic. Thank you so much.
Fantastic. Gosh, that throws up a lot of issues, doesn't it? Huge amount of issues. And the sort of, I've been scribbling my own little notes, thinking about the choice. It really does highlight what choices are. And I think your point about, fitting women having to fit the system rather than it being centered on women's needs was really good one on both sides. It came through really quickly and clearly on that. So thank you very much for setting the scene. We have got some questions. Now, anyone who's watching, forgive me if I turn away because that's where the questions come in. And we've had a lot of questions so far, some of which are quite big questions, I have to say. So Gamal Mohammed, hi Gamal, says, how safe is ripening at home? Any dangers involved? There's a good one to start. I think that might be one for Mairi.
Yes. Well, we just don't have the evidence to know that yet, and that's what the main choice study is all about. So the main choice study took a large cohort of women, and we will be reporting the findings on that, but they aren't quite available yet. But certainly a lot of maternity units have started introducing cervical ripening at home, and their experience of it does seem to be that it's safe, but we're waiting on the evidence to back that up.
Thank you. I mean, I thought it was useful highlighting that we're moving towards a lot more inductions than the service can handle, and maybe some that don't need induction. And I know that's a discussion that's gone on as long as I've been a midwife. So we're moving on now to Sheila Brown. Hi, Sheila, who says, what benefit is there of being on an antenatal ward? Women are not monitored and often ignored. What does auscultating the FH every few hours tell you? Is that another one for Mairi?
Well, I mean, I think that's interesting, but I think it is also important to say that some of the women that we maybe it didn't come across in our presentation so much because we were quite limited in the findings that we could present, but some of the women we interviewed, and certainly in the postnatal survey, they wanted to be in hospital. They felt safer. And I think, when you've been told that you need an induction of labour, precisely because the pregnancy needs to, your baby needs to be born because it's more risky for you to continue your pregnancy than for the baby to be born. And then that certainly creates some anxiety, and some people just want to be in hospital and will feel safer there. So there are, for some people, there are advantages from that perspective alone. I think we could probably argue this way or that way about the physical safety of it, and hopefully the choice study will help answer some of those questions when those findings are published.
I think the idea of being in 11 days as well was quite stunning, actually, wasn't it?
It is, but it was really interesting because that woman actually described a good experience, and the reason that she did that was because the staff were so good to her and so kind to her. And I think that was something, you know, that really came out in the survey, was that as midwives we really do have a power within us to impact people's experience, even when it seems as though it's, you know, from our point of view, it looks as if they're having a really horrendous experience. Actually, you know, if we're kind and respectful and we value them and we keep them informed, then we can mitigate a lot of that. I'm not saying it should happen, it should never ever happen, but there are things that we can do to help that.
Yeah, that's a good point. Thank you. Okay, now we've got Nina, who says, do all women who undergo induction of labour require cervical ripening?
Sorry, Cassandra.
Well, I'm not a midwife, but in my experience from doing this research, just to give you a break, Mairi, not all women do require the cervical ripening first. If that, well, you can go ahead there from here, Mairi, since you're the midwife.
No, well, it's nice guidance now that for most people, cervical ripening should be the first thing that happens during an induction of labour. I think there'll be some women, particularly those who've had a spontaneous rupture of membranes, where it's not appropriate. But for most women, it is recommended by NICE.
Okay, thank you for that. Okay. And then Rosalind Fox Bentley, hi Rosalind, says, how much of an effect do you think COVID restrictions made to the responses? And I know Mairi talked a little bit about that, and Cassandra, actually, you did talk a bit about the impact of that.
I don't know, Mairi, do you want to go ahead first? Or...
Yeah, I mean, obviously it changed the whole context that the study run in. And, you know, you do have to take that into consideration when you look at the findings, particularly around people's experience of being in hospital. And the decision to stay in hospital or go home was different, because some people didn't want to come into hospital because they didn't want to be exposed to the virus. Some people didn't want to go back and forth because they might be taking the virus back and forth. So, you know, it did change people's decision making. But I think, you know, the core findings that we have probably around induction of labour are things that were universal and not necessarily that impacted by the COVID pandemic. But certainly, I think you can't consider this study's findings without understanding that it was done at that time. Cassandra, I don't know if you want to add to that.
I mean, certainly some of the things that we hear about, you know, the policies and looking at that from the clinicians' perspectives and their practice was obviously impacted by the fact that they were working during COVID-19. And obviously the amount of cervical ripening that at home that was being done, and to the extent to which they were able to put those policies into practice, and the disruption to that certainly had an impact. But again, you know, we had one site that the pandemic hit and they, you know, made home cervical ripening the default. And we had another site where decided to suspend it altogether. So there were really different responses to that as well.
Okay, that's grand. Thank you very much. So we've got now, this is a comment from Sheena Byron. Hi, Sheena, who says, these findings of trauma are reflective of so many stories I hear from women and midwives. This is such an important study. Good to hear some positive experience, and thank you, Mairi. She says, thank you for that, Sheena. And Sheila Brown, hi Sheila, says, were all respondents past the wider study, and has there been any work from the social actor from practice in relation to the usual care, i.e. not influenced by research intervention? Who would like that one? Cassandra?
I hope I understood it correctly. I think in terms of the research, the first part of that question, which was, were the research participants part of the wider study? So yes, all of the Q choice sites that we had were also choice study sites. So that was a requirement. So, but our data was not linked to, so there was obviously routine data collected as part of the choice study, as Mairi said, those records, but those records were not linked to the people who filled out our survey or did our interviews. But yes, their data was part of the wider study. As for the second one, can you just say it again, Sue, so I know?
Has there been any work from the social actor from practice in relation to usual care, i.e. not influenced by research intervention? I think that's the issue of, as soon as you ask a question, the answer starts to change because you're asking the question. I think that's whether the research impacted on the answers that were coming in. I think I understand that right.
Yeah,
I hope so.
Of course. I mean, thank you, Sheila. This is a question that, a consideration that we always have when we're doing qualitative research, as to understand that, your position as a researcher and coming in, particularly as most likely as an outsider, does really impact the type of discussions that you have. I think that really the strength of our study is, obviously Mairi is a registered midwife, as well as a very experienced researcher. I'm coming from a medical anthropology background. We had a lot of different, even though we were asking similar questions, the conversations that we had were often different, and the types of questions that we asked were often different. And I think that made it a lot stronger, and it's something that happens sometimes in research. In terms of having that more insider look, I think sometimes we did do focus groups. And we did have instances of focus groups during this study where the healthcare professionals very much interacted and had discussions amongst themselves without very much of our input about this subject. And we found that, even given the challenges of maternity care work during this period of time, healthcare professionals and clinicians were really we're keen to speak to us, and we did have a lot of participation. So, obviously, it's impossible to remove our influence as researchers completely, but we do our best to reflect on it and make sure we take that into account in our analysis.
I mean, I was seeing it, I mean, I've jotted down, and I thought that was a really good point. And because I wonder, especially when you were describing the woman who said she was never going to have another baby again, I wondered if by writing things down or being interviewed, that might have helped just kind of make her move on a little bit. And you'll never know, but it's kind of, you kind of like to think that part of the research process might actually help the participants as well as us to understand what's happening. But yeah, that's good question. You see, our participants are lovely. They come up with some good questions. We've got Jill Moncrief, and she's asking or saying something that I wanted to say, which was, thank you, Jill. She says, so intrusive to call women in the middle of the night in their homes just so they fit with the needs of the system. I was kind of thinking, I wonder if that, when you learn about induction, isn't it meant to be working with the woman's hormones? And you just wonder, 1 o'clock in the morning, oh dear. I don't know if anyone came up with a kind of question on that, or in the research team. It just seems...
No, I mean, in the staff's defence, they were working in a system where as soon as a bed came up, they just had to fill it, because, the system was really just cracking on all sides. But yes, absolutely awful. And awful for women to think that, if they get phoned at 1 o'clock in the morning and they don't answer their phone, or they don't pack their bag immediately, or they don't have transport, then they miss that slot, and the induction that they're so anxious about gets set back again as well. It's horrendous. Yeah.
Very stressful, very stressful. Thank
We
you for
have
that.
very, I think could say that, don't want to say, put the blame on staff who are working in conditions that, really, really challenging under an extreme amount of pressure. And, we recognize as well the fact that, no one wants to provide care like this. But unfortunately,
absolutely.
this is the reality of what they were discussing. And so again, being able to provide that space during the interviews and focus groups for staff to discuss this, was, I think, from the researcher point, seemed to be important. So we just wanted to say thank you to all of our participants, our staff, NHS staff in particular, for giving their time. Yeah.
Fabulous. Thank you. We've just got a few more. We've got, when will this is Sophie Webster. Hi, Sophie, is saying, when will the results from the main choice study be available? The whole thing. Is that Cassandra?
I'm not entirely sure of the timeline. We'd have to talk to our colleagues at the moment to see where they are. We have submitted an IHR report to our funder, which is, under peer review. And so we're hoping that we will be able to disseminate and publish a majority of the results this year. So
fabulous. So people need to keep an eye on Twitter, because that's a place you get information very early. Thank you for that. Now, Joe Guston says, thank you for the critical analysis. Calling women at 1 a.m. indeed. Well, we had that. It's clear that staff are doing their best to cope, but the extra workload of so many inductions is immense. How well are staffing tools addressing this? Not sure that you'd get the answer to that one, Joe. And then and Sheena Byron, thanks Sheena, is saying, can I ask what next with the study? I think you did discuss what the other bits of the study, but I wonder if you'd like to remind the audience what next with this study?
So we've stopped collecting data, and the data analysis is pretty much complete. So we have a huge amount. So it's really just, working together and pulling together papers and trying to disseminate findings as much as we can. So I kind of watch this space, hopefully, for a few more papers and a few more perspectives on the data that we've collected. Cassandra, I don't know if you've got anything else that you'd add to that.
No, I mean, pretty much the same thing. I mean, we have these two, as mentioned, these are two preprints, so they're under peer review right now, and they will both be, the plan is that they will both be open access, as I imagine most of the choice data and publications will be. So hopefully make those be more available to everyone.
Fabulous. Well, I think I always say this hour goes through so quickly. It always goes quicker than any other hour in the week. And we need to come to an end. But I want to say a big thank you to Mairi and Cassandra for sharing this project. And as they've pointed out, this is a massive piece of work, and there's more to come. And there's plenty of bedtime reading. And as Cassandra, I think, pointed out, some of the tables that are really interesting, you need to have a look yourself, and you can print it, and it's all free access. Fantastic. So do take your opportunity of going in and checking it out and reading it. So thank you very much to our wonderful speakers, and thank you so much to the audience for coming up with some fantastic questions. We might have missed a couple because they come through slightly slower, but thank you for all of those who participated. I'm just going to say a quick thank you to Amy, who's behind the scenes making sure this is all beautifully recorded, for those of you who might miss any or want to share with your colleagues, and also Paul for getting the questions through to me. Also, the resources will be available on the website, and you have your podcast on Friday morning at 6 o'clock in the morning. Next week on Maternity and Midwifery Hour, we've got midwifery staffing levels and postnatal care with Leslie Turner and Elizabeth Duff. Don't forget to book for Safer Beginnings Conference for Healthcare Professionals and Educators, and that's the Best Beginnings and White Ribbon Alliance. 3rd of March, London, and 10th of March, Manchester. Don't forget, 7th of February for the London Festival, if you're in the vicinity. And in the meantime, another big thank you to Mairi and Cassandra. A happy Burns night. And thank you to everyone. Stay safe and be well.